Right. You can see that, I hope.
See the first one, yes.
Okay. So this talk is based on a lecture I gave to Diabetes UK. I was asked to give appropriately the Banting lecture, which is a lecture that Diabetes UK asks people who've done research which they recognize as, well, I suppose, as a way of thanking them for doing their research and doing them the honor of presenting it. And this is what this lecture is based on, but I've changed it a bit. So it's exactly 100 years since the discovery of insulin. And 100 years ago to this very day, Frederick Banting, who I'll tell you about shortly, was engaged with his colleague, Charles Best, who was a medical student who was employed for the summer to try and solve the problem of diabetes. Can you see my next slide?
Yes.
Good. So what you see on this slide is Sir Frederick Banting. Banting as he'd served in the First World War, and in 2019, having earned the Military Cross for bravery, he was a surgeon. He returned to Canada and tried to set up a surgical practice as you had to do in those days. He really struggled in Toronto, so he went to a place called London, Ontario, which was 100 miles or so away. He set up practice, and for a year he tried to make a living, but found it very frustrating. He was not trained in diabetes. He knew very little about it. But he began to develop a theory which would develop and discover the extract from the pancreas gland. It was known that there was something in the pancreas gland which might treat diabetes. And in those days, people only knew about type 1. It was a fatal disease in everybody. It had a prognosis much worse than cancer. And because it affected young people, it was a real tragedy, a huge global problem. And the only way that these young kids could stay alive was being starved to death in the end. And here you see an example of what these children looked like. They'd been on a starvation diet. It kept them all alive, sometimes for up to a year, but at terrible cost to them. And many of them died of starvation rather than a ketoacidosis, which was the other way. Banting believed that if you could tie off the pancreatic duct, which was the sort of where the digestive enzymes developed, then you would, the pancreas would atrophy and the cells left would be the insulin producing cells. So he set to work trying this theory, and Professor MacLeod, who was the head of physiology at Toronto University, allowed him to spend the summer, although he was pretty skeptical. He was a Scot working in Toronto. He got Charles Best to help him, and they sacrificed dog after dog after dog in their vain attempts to try and find this extract. The problem was that this hypothesis wasn't true, and what you needed to do was extract the insulin-producing cells from pancreas glands, but they just couldn't work it out. But by luck, eventually they found a preparation, and here they are with a dog. And if you want to read one of the really great books about the discovery of insulin, appropriate 100 years ago, it's still available today. And I'm just going to show you the book. But if you can get a copy, it's available through Amazon. It's a paperback, and it is a truly dramatic story. So here's a dog, one of their many dogs that they got rid of. It's said to be the first dog who got insulin and survived, but I'm told that actually isn't true at all. They're on the roof of the physiology building in Canada, Banting on the right, Best on the left. You can see he was much younger. Actually, the person who made the real difference was this guy called James Collip. He was a biochemist, because he began to realize that what they needed to do was actually extract insulin from pancreas glands of animals. And he worked out with a combination of acid and alcohol, you could get enough insulin to make a difference. So without him, Banting Best would never have been even heard of because insulin would not have been discovered. The problem was that Banting was very jealous. He didn't like to give credit to Collip, and indeed it is said in the book, there's a thing about them almost coming to blows about this. The other thing which I think is interesting and important is that Collip is responsible for devising what a unit of insulin was, because you couldn't measure insulin in those days, and you had to do what's called a bioassay. And what a bioassay is taking the product that you're interested in and doing changing something in usually an experimental animal and seeing what happens and calculating that. So a unit of insulin was the amount of insulin which was needed to give a rabbit a hypoglycemic epileptic fit. And that is how the first units of insulin were discovered. And of course, we still talk about units of insulin, but luckily we're not sacrificing rabbits anymore. We measure it by a proper radioimmunoassay. So I will cut a dramatic story short. The first person to be given insulin was in, I think, January 1922. And instantly, Frederick Banting became famous. In fact, he was awarded the Nobel Prize with Professor MacLeod in 1923. So it was a great year for him. But there was a huge falling out because he was furious that the Nobel Prize Committee didn't give some of the prize to Charles Best, the medical student. And MacLeod was equally cross that Collip, who he felt should have got most of the credit, was also unrecognized by the Nobel Committee. So I'm told that they each shared their prize. But the relevance I'm showing you this is just the first paper talking about a hypoglycemic reaction. It was published by Frederick Banting in the British Medical Journal in 1923. And he had the foresight to say that hypoglycemia was going to be a real source of danger. We then have to fast forward to 1941 to somebody called R.D. Lawrence. He was a physician at King's College Hospital, and he had diabetes himself. He had gone away to die in Italy when insulin was discovered. He rushed back to the UK and his life was saved. And he then devoted the rest of his life to treating people with diabetes at King's College Hospital in South London. And he describes the first clear description that as he continued to treat himself, and he treated himself very tightly, then his warnings of hypoglycemia began to change. The sweating, shakiness disappeared. And the first he knew of being low was that he wasn't thinking straight. He was losing concentration. And to this day, that is exactly what happens in long-standing type 1 diabetes and in some people with type 2 diabetes. So this is another very important paper, and it was a description of the first proper description of impaired awareness of hypoglycemia. But we really had to wait till the 1980s to make progress in really understanding what was going wrong in hypoglycemia, because that diagnosis, as you're about to see, people with type 1 diabetes, and most of the work was done on type 1, although I'm going to talk about type 2 as we go through this presentation. The diagnosis, the protective mechanisms which prevent you from having a severe hypoglycemia are all there in people with diabetes. And what's really interesting, it isn't until you develop diabetes that you begin to find changes which make people with diabetes much more vulnerable. So one of the first take-home messages is that hypoglycemia in diabetes isn't just because you take too much insulin or you don't eat too much, And I want to point out that these are all things which doctors and perhaps nurses have done, sort of blame patients for getting it wrong. And in textbooks to this very day, you'll see those are the cause of diabetes. But actually, it's very misleading, because the cause of hypoglycemia is that people with diabetes are uniquely vulnerable. And this study, which actually inspired me to spend my life studying hypoglycemia, because I started training in diabetes in 1982. I won't tell you how young I was, but I was a hell of a lot younger than I was now, as you can tell. And I was very intrigued by this paper, which my boss, Robert Tattersall, who sadly died in Sheffield, actually in December, sent me, and it got me really interested in knowing what went wrong. So people were trying to understand why people with diabetes were so susceptible to hypoglycemia. The insulins weren't very good in those days. And by the way, urine testing was still being done, although blood glucose monitoring had been introduced in around 1980. But many people, including children who I treated at diabetes camp as a medical officer, were still using urine testing, a completely useless way, of course, of managing diabetes. Anyway, people wanted to know what was going wrong, and they thought that if people had perfect glucose control, they might preserve their responses. Because what you needed in order to avoid hypoglycemia, if you were using insulin, was a release of adrenaline and also a release of the hormone called glucagon, which is made in the cells adjacent to the beta cells in the pancreas gland. And really importantly, those cells continue to work normally, even though the beta cells, which make insulin, are being destroyed by the autoimmune process, which takes them away over 10 years sometimes. So let's look and see what happens. So these investigators in the States, Jerry Bolli was the lead. He was an Italian who'd gone to work with a guy called Jack Gerich at Minnesota. And they used a simple experiment. They reduced the glucose with an insulin infusion to 2.5. They measured adrenaline and glucagon. And on this slide, you can see the adrenaline in dark blue, the glucagon on the right, in people who don't have diabetes. And you can see at 2.5, they spark up quite a lot. Look at the response in people who've been diagnosed 4 weeks with type 1 diabetes. It is exactly the same. In other words, at diagnosis, people with type 1 diabetes, and indeed type 2, have a completely normal response to hypoglycemia. And because these two hormones do two things, one, they break down, they tell the liver to break down its glucose store, which are glucose molecules attached to each other. We call that glycogen. So breaking down glycogen defends the body against the glucose lowering effect of the insulin, and it is very effective. In fact, it makes severe hypoglycemia incredibly unusual in the first year of diabetes. Now, probably most of you don't remember, those of you with type 1, exactly what was happening, but I bet you when you did go low, you were sweaty, you were shaky, but your body was pushing your glucose up automatically. And the other thing is, of course, adrenaline is telling you, the sympathetic nervous system is saying, hang on, I'm really stressed. Something's going wrong in my body. It could be that they're very frightened because somebody's chasing them. So we have the fight or flight reflex. But in diabetes, of course, it's hypoglycemia, which the body recognizes as not normal, because it certainly isn't. The adrenaline is produced and the sympathetic nervous system makes you sweat, shake, your heart pounds. And those are, of course, the classical symptoms which we teach people to identify as hypoglycemia, to take action by taking some quick-acting carbs. So those are the two essential components which protects you. 1 month, everything's fine. Look at what happens after just 1 to 5 years of diabetes. The adrenaline response is pretty good, but the glucagon response has gone down by 2/3. And glucagon is just a fantastic hormone for protecting you from hypoglycemia. And all of those of you who've ever used glucagon as emergency treatment, in your refrigerator know that. It makes your glucose go shooting up, although when you inject it, it also makes you feel very sick and often vomit. But nevertheless, without it, you're already at increased risk. So within 1 to 5 years, people with type 1 diabetes are already at risk. And after 15 years plus, as we showed in other studies, you can see both hormones are really screwed up. They're not really released. And I want to emphasize, they work completely normal if you're running. Your adrenaline will go up the normal way. And glucagon, if you inject the right thing, will also go up. In fact, in poorly controlled diabetes and ketoacidosis, glucagon release is very high, too high. So these hormones can be released, but they don't respond to hypoglycemia. And that was the mystery. So we knew in the early 1980s that people with diabetes are very, much more likely, and yet they still get blamed for taking the wrong dose of insulin or missing their meals. But I think certainly in the 1980s, was when I was being trained, although luckily by a very insightful consultant, he said we should not blame people. This is a really complex treatment, and they are losing their defenses to hypoglycemia. And hypoglycemia is almost inevitable if you achieve the glucose goals which your doctors have for you. So this was the next thing. Well, could we, and when I was being trained, this was the thought, if you could keep glucose perfectly normal, which is very difficult to do, could you restore these defensive weaknesses, the hormones going away? And so what was done was to take people on the very first pumps. Many of you might be using pumps, but actually pumps were used right at the beginning of the 80s, started by Harry Keene and guys, and eventually in America, to ask the question whether this was a perfect way of controlling glucose and preventing complications. So that's been going on a long time. Anyway, let's see what happened. So here's the adrenaline response. We're not measuring glucagon anymore because it's already disappeared in most people. You can see that in a non-diabetic population, we get normal adrenaline response at just under 3 millimoles per liter. You'll look at these people before they've been on pump therapy. You can see that they're already got a damaged adrenaline response to hypoglycemia. So if the hypothesis is right, that adrenaline response will be restored. Let's see what happened. Oh, it went down even more. So far from restoring the adrenaline response to normal, it is impaired. So everybody was really puzzled. How on earth, what was going on? What could have happened? And in other studies, some done by my friend and colleague Stephanie Amiel, who became a professor at King's, in fact, the R.D. Lawrence professor, though she's just about to step down in September, which is very sad. She showed that the reason that the adrenaline was impaired is it wasn't being released as it should have been at 3.5. It was being released at 2.5, and nobody knew why that was. And I was working away in Nottingham, and I got this crazy idea that could it be that hypoglycemia itself could be the reason that these responses became impaired. And the reason that I thought about it is I was friendly with the professor of physiology there, Terry Bennett, and he said to me, because they were doing studies in hypoglycemia, he said, the very first time I ever had a hypo, and he didn't have diabetes, but he was made hypo in the lab, he felt terrible, he sweated and shaked, but he said, I then had a few more over the next few months. And by the end, I didn't feel bad at all. I didn't sweat, I didn't shake, it seemed fine. And I thought, wow, that's interesting. Could it be that hypoglycemia itself is doing it? So I went off to work in America. I took my family with them, me, 4 kids, and Judy, my wife, and we were very broke because we had no money, but it was fun. We took all the kids to Disney World, but I did do some experiments, and this was the experiment I did, and it turned out to be a good idea, as you'll see. So we took medical students. We had to pay them quite a lot of money to be made hypoglycemic. And so we brought them up one morning and we made them hypoglycemic. And here you can see we've lowered their glucose to 2.5 and we're measuring their adrenaline. We also measured glucagon as it happened, but I'm going to show you their symptom score because I worked out that we needed a symptom score to measure their sweating, their shaking, their confusion, which would give us a sort of idea of how strong their warnings were. And on the morning, on the morning, we made them low and we tested them. Then in the afternoon, we kept them low for a couple of hours at 2.8 on one occasion. And then the next day, we brought them back again. And on other occasions, we didn't make them low. We didn't tell them when they were low in the afternoon, although obviously they could usually tell. And we tested them the next morning. And this is the result. You can see that 24 hours after they'd been made low in the afternoon and we tested their response, their symptom scores had gone down and their adrenaline response had gone down. And so what we showed is that one of the really important causes of impaired awareness is repeated episodes of hypoglycemia. And I still remember doing the experiment with a medical student. In the first morning, he'd sweated, he'd shake, he looked terrible, actually, as those of you who had a bad hypo will know. And the next morning, he said, oh, this isn't so bad. He was essentially, we'd made him a hypoglycemia unaware the following day. And since then, I was quite worried when we did the study because I thought, supposing we've got it wrong. But very quickly, other people did it. They showed that we were right. It was then done in people with diabetes and in people with type 2 diabetes, and the same thing is done. And so this is a very important cause of impaired awareness. So where were we? So in the early 1990s, when I came back from the States and became a consultant physician here in Sheffield, and my first consultant job, we learned the following, that defenses to hypoglycemia were normal at diagnosis, were consisted of these hormones, which released glucose from the liver and generated symptoms. But the longer diabetes went on, and the same is true in type 2, if you're on insulin, you begin to get impairments. These hormones don't respond to hypoglycemia. They're not released properly. The symptoms are less strong. And what is happening, and I'll go over this again if I've not made it clear, is that if you get these defenses above 3, then it's at 3 that your brain begins to stop working. You begin to have long reaction times. You're not as aware and alert. And if your responses are generated at 2.5, by that time, in many people, not always, some people can even be lower than 2 and sort of think they're functioning normally, but they're living on borrowed time because their brain is desperately trying to suck glucose out of the bloodstream to keep working. Because as many of you know, the brain, the cells operate on a 5-star fuel, which is glucose, whereas the rest of you, your heart and other organs around the body, your kidney, do not need glucose to work. They can work on, if you like, 2-star fuel, which is the breakdown products of fat, for example. So it's the brain which isn't working. You're generating your symptoms, but actually you don't know you're low because you can't recognize them because your brain function's impaired. And that is what is going wrong. And that explains why often relatives say, you know, you're low. I don't think I'm low. I think you should test. No, I don't think I need to. Oh, I am low. That's a surprise. You know, these are the kind of things which are being said so often, and I don't think we've explained them well. So what are the causes of impaired hormonal defenses and reduced awareness? Well, one, long duration, and clearly you can't do much about that. We still don't really know why. My own theory is that all the hypos that people have gradually damage the little cells in the brain, at the base of the brain, in the hypothalamus, which tell you that you're low and switch on the hormones. But and we could do studies in rats to do that. And I keep trying to persuade my colleagues who do rat experiments, but they all don't think it will be very interesting. I think it would be a really fascinating study to do. And one day I'm going to persuade somebody to do it, but it won't be me. Increasing age. So interestingly, at the age, your brain function begins to become impaired, not at 3, sadly, but about 3.5 to 4. And of course, children can't respond. Increased physical activity obviously takes your glucose down. And I think the adrenaline that you need in order to run kind of gets mixed up with it, while people who do a lot of physical exercise can be vulnerable, of which more we can discuss. Use of drugs. Alcohol is important, as all of you know, not because it makes you hypoglycemic, but because it interferes with the liver's ability to push glucose up again, which is why I always tell people when they drink, please run a little bit higher than normal and don't risk going low. And of course, the other thing is, if you're drunk, it's often not very easy to tell whether you're low or just drunk. And sleeping is important. Again, this hasn't been well recognized, although some really good research has been done. When you're actually asleep, you suppress your adrenaline. So even if it's impaired already, it gets further impaired during sleep. And so, as you can see, if you've lost your most important hormone, because the glucagon has disappeared, it's going to make you vulnerable. But tight glycemic control with repeated episodes is probably the most important thing for a number of reasons. Partly because it gives this impaired awareness. It's incredibly common, impaired awareness. About a quarter of everybody with type 1 diabetes has a significant amount of impaired awareness, although luckily our driving authorities haven't noticed and they can allow you to drive, as they should. 1 in 10 people with type 2 diabetes on insulin also have impaired awareness, and sadly, it's not recognized enough by people who look after them, often GPs, to no fault of their own. And the reason it's so important is that we've shown, or been shown in repeated studies, that if you have impaired awareness, your risk of having severe hypoglycemia is up to 6-fold higher than people who don't, almost certainly because you're just not making adrenaline and you're really vulnerable. And I think I noticed one question. This can result from just 2 or 3 episodes of hypoglycemia, probably below 3. We're not sure. It could be just above. It's probably significantly less than 4, however, and that's enough to generate it. So that's why I believe that people who have good tight control can run into problems over the years. And in our very first paper, which we published describing those experiments in people without diabetes, and we said, maybe if you could avoid all hypoglycemia, that would bring that back again, bring your warnings back. And the answer is it can. Right, so let's move on. And this is the experiment. So there's been a number of studies, but I want to talk about the one that Stephanie did, because of course she's my friend. And so she had read our paper and thought, let's take people with impaired awareness. Let's stop all hypoglycemia for a few weeks and see what happens. So on this slide, you can see they worked out the threshold for the onset of hypoglycemic symptoms. You can see it's just above 2 in 12 people with quite bad impaired awareness. You can also see they measured brain function. As I told you, it begins to go off around 3. And we'd done a thing called a 4-choice reaction time test, which is a very sensitive test. And she used the test. I think we suggested that they should use this test because I was working with a very good friend, Ian MacDonald, and he and I had discovered this test. And you can see what happens in people with impaired awareness. They're not getting their symptoms before their brain is being switched off, which is a bad thing. Look what happens with 3 weeks absence. And I should say it didn't take 3 weeks. It took about 6 months because it was very difficult to persuade people to avoid all hypoglycemia. It was very difficult to do back in 94 because we didn't have Libra devices, and not many people were using pumps. So actually it meant a research fellow ringing people up very regularly, 2 or 3 times a week, and getting them to adjust their insulin. Eventually, he managed to get quite a few to reverse, and look what happens afterwards. You can see that their symptoms are now coming on just above 3, which means they've got some of their warnings back, and it's much safer. So what can we do to prevent it? You might have thought 1991 is when we did the study. We should have worked out a cure for it now. And here we are, what, 30 years later. And I'm sorry to say, we do not have anything. Various things have been tried. There was a series of papers in the mid-90s that you could use caffeine. Yeah. Sorry, is there a problem? Or can I carry on? No? Okay. The caffeine hasn't worked. Somebody suggests a drug called modafinil might work, and that was tried. I'm afraid it doesn't work either. The only thing which is cheap and cheerful is Daphne, because it teaches you how to use your insulin safely. It doesn't make you any less vulnerable, but we realized, a few of us back in the mid-1990s, the Germans had discovered this, of course, a lot earlier, 15 years earlier, that people needed skills and we had to train them properly, which we did. And that's a photograph of the very first Daphne course. I recognize a couple of people who did it. So teaching people to use skills and use intensive insulin therapy safely will reduce the amount of hypoglycemia you have, reduce your impaired awareness, and reduce the number of severe episodes. It's very cost effective, and I hope many of you with type 1 have done that course already. You should have done. So Daphne works, but it doesn't change anything. It's not a miracle drug. It just teaches you to use insulin safely. There are no other ways at the moment, and we're going to have a big conference in Washington, in America, in October, to get all the best people in the world to say, why the hell haven't we done better in 30 years? What's going wrong? What's the secret? Is there a miracle medication which can prevent it? So what are we doing? We've got better insulins. I'll talk a little bit more about that. We've got insulin pumps. And of course, we've got continuous glucose monitoring. And I'm going to mention this again, but if all else fails for people with very severe awareness, we can now do islet cell transplantation, although because it's only available to about 5 people a year, perhaps a few more, it's not really a realistic treatment. So let me bring you up to date and say, well, where are we with hypoglycemia today? How risky is it? And aren't all the new treatments, Libra, continuous glucose monitoring, pumps, something called hybrid closed loop, making a big difference? Well, I'm afraid not. Partly because it's expensive treatment, and partly because we're still not very good as healthcare professionals at teaching people to use insulin safely, I'm afraid. Some round numbers for you. This is a study from Dundee. It was population-based, and by that I mean they took everybody with diabetes, because they in Dundee they've got this great IT system. They can identify everybody, and they persuaded a random sample of people with type 1 and type 2 on insulin to have their hypoglycemia measured in great detail. And so you've got some round number. On average, people with type 1 experience lows approximately once a week. In type 2, it's about a third as much. Severe events, which we define as needing the help of another person to recover, occur on average in type 1 diabetes 1 a year, and in people with type 2 diabetes, about a third as much. So round figures, but actually fairly meaningless, because again, as many of you will know, some people never have hypoglycemia or to speak of, certainly severe episodes, while others get a lot of episodes, and often because they're terrified of hypoglycemia and they're keeping their glucose very low for all kinds of psychological reasons. And if you think new treatment has made a difference, here's a study from North America, which the results were presented at the European Diabetes Association meeting, which I was at virtually last September. And hypoglycemia is even more common in this study across America, the richest country in the world, where you'd think the care would be great. So overall, there were severe hypoglycemic events around 2 times for each person every year, 3.5 average for the type 1 and 2.2 for the patients with type 2. So don't think that if you are treated with insulin, you're without risk. And if we look at the proportion affected, you can see that's 50% of the type 1 population is at risk of having at least one severe event. And of course, in Europe, having 2 severe events means you lose your driver's license. And in type 2, it's 33%, a third of the type 2 population. So it is a huge problem. So these are a summary of those results. You can see that very few resulted in hospitalization, mainly because I think they were treated at home, 90% in severe events, and a half of them didn't require a paramedic. It needed relatives to help them out, and that was where they were. So this is a kind of summary of where we are. I haven't got time to go through it, and I didn't want to sort of scare people hugely, but this is, if you like, the effects on the body. I'm not going to spend any time on this. I'm just going to mention the fact that, of course, we know the brain can be affected. We probably should talk about whether repeated effects can cause dementia, because it's obviously something that we're worried about. And I'll talk about that in the discussion. Of course, if you're driving, you can have musculoskeletal injuries, both you and indeed somebody else you might crash into. And sadly, that still continues to happen. I have been in court trying to keep a 21-year-old out of prison because he hadn't tested. He crashed into somebody else. They died. And I was unsuccessful. At 21 years old, he spent 3 years in jail. The other thing is that I think we do have to accept, and this is particularly important in people with type 2 diabetes who already have some heart problems, that hypoglycemia can increase the risk. We have led the way, actually, in Sheffield in doing studies to try and discover, 1, if it's true, and 2, what it's due to. And I think it's probably due to hypoglycemia causing inflammation, making your blood more sticky, and damaging the blood vessel walls. So if you already got coronary artery disease, you can see how that might increase your risk of heart attacks. And the evidence is, it's not huge, but it's definitely there. And we think that's one of the reasons that trials in type 2 diabetes, which have controlled glucose very tightly using insulin, haven't made any difference to heart attacks or strokes. We hope they would reduce. And indeed, a study in America actually increased mortality. And we suggested in a paper we wrote that that could be due to it. There's been lots of controversy. Some people don't believe it. Of course, you cannot do a trial where you randomize people to have hypoglycemia and see what happens. But I think the evidence is pretty overwhelming that it definitely contributes. So the problem in diabetes is this, and that's the problem that we all face, I think. We, of course, encourage people to control their blood glucose. We know it reduces complications, and complications, if you get them and they're bad, will have a devastating effect on your quality of life, as well as being very expensive. On the other hand, if we use treatments which cause hypoglycemia, then it's going to get people to run high. It's going to have huge effects, impairing their quality of life. That in itself will increase the risk of complications. and that will be expensive. So that is what we have to try and do better. And I have to say, frankly, in the 40 years I've been practicing, we haven't done a great job, although I think things are improving. So a bit about what are the risks, because these are things that you should know about just as well as the doctors. Clearly, if you're running very tight levels of A1C, that's a risk. Not for everybody, but certainly for people with type 1 diabetes, I worry if they have HbA1c levels less than 6% in old units and around 50 in new units. And interesting, the evidence is that if you started off high in type 2 diabetes and go insulin, you have a high risk. My belief is it's because you find it difficult to sort of engage in your own self-management, but I don't know for sure. A long duration of diabetes, I've mentioned. Previous hypoglycemia, particularly severe episodes, is a risk factor, and that is why people lose their driving license, although I think it could be a bit more thoughtful. Impaired awareness is important. It does increase the risk, as you've heard, although in the UK and indeed across Europe, if you have some awareness of hypoglycemia and you are testing these days, of course, with continuous glucose monitoring, then you can keep your driving license. If you are driving HGV vehicles, which people can, and you have impaired awareness, then you should not drive. Although I do see drivers and assess them, and I'm afraid that quite a few don't tell me the truth. Big insulin doses are important, and being physically active is another. Just briefly, how to treat a hypo. This is something everybody should know about. Eat or drink 15 to 20 grams of fast-acting carbs. These are some of the things which work well. The best is a dextrose juice. Lucozade is the quickest acting, frankly, and it isn't really there, but it would be what I would recommend. So a bottle of Lucozade, 200 or 300 mils, and then wait. This is very easy. Test 10 to 15 minutes later and check that you're on the rise. And try to eat 15 grams of slower acting carbs. There's been one of the questions saying that my 11-year-old son uses this as an excuse to eat bags of crisps and is putting on weight. What do you do? I don't know, but you could tell him, I'm sure he'd be delighted, that a piece of fruit such as a banana would work just as well. It would be in your system quicker, and it hasn't got the kind of calories that a bag of crisps has. So that would be my recommendation. And in Diabetes UK, it says, if you're feeling too drowsy or confused to eat or drink, ask someone to help you. Well, that's pretty obvious, I think. And I'm going to just go on. If you are there when somebody's having a severe hypo, I was on a plane once, and it's one of the few times I was useful. Put them into a recovery position. Give a glucagon injection if you know how, but it's a hopeless treatment, although you're about to hear that light is here at the end of the tunnel, and call an ambulance. I actually, personally, particularly at children's camp, have tried to get a glucose drink down somebody who's semi-conscious. People get terribly worried they're going to inhale and get something disastrous, but as long as they're semi-conscious, they're probably going to have a gag reflex, and it does work, but glucagon is much better if you have it. Am I going backwards? Patient education. Well, you might as well know what the education that's recommended. Discuss hypoglycemia risk factors. This is for doctors, and treatments. Educate patients on how to recognize and treat. You should know that anyway. And most important of all, please report hypoglycemia to your doctor. It's one of the few questions I try and ask every time. I suppose I would. And everybody should have had structured education. In this country, only 10% take it up, which is horrific, because 40% are offered it. And I think their doctors and nurses aren't selling that to them. And we've recently been participating in a study which Stephanie's been running on blood glucose awareness training, and we're going to see the results very soon. So how can we address hypoglycemia? 1, improve education. 2, develop better insulins. New insulins are much better, as are insulin pumps, compared to the very old insulins, and nobody should be on human insulin or animal insulin for that reason, in my view, if they have type 1, or indeed type 2, if they're using insulin to treat, get their glucose as close to normal. And we have new technology, which is pretty good. I do think that Libre devices are a game changer, as long as you have the knowledge and enthusiasm to do something with it. And it is fantastic for those who will use it properly, scan properly, put the results on their phone, share them with a healthcare professional. It can make a difference, particularly with alarms, although the alarms can be a real nuisance. Continuous glucose monitoring is better than Libre, and Dexcom, in my view, and there are 1 or 2 other sensors, Medtronic's not bad, are pretty good. This is a low glucose insulin suspend pump, which is fantastic as long as people don't fiddle around with it. It can make a real difference. It switches off insulin automatically when glucose goes low. And transplantation is there if necessary. People always ask me why you can't have a pancreas transplant, because it can make you come off insulin. The reason is it's a very hairy operation, has a significant mortality, and you have to be on immunosuppressive drugs, which can increase the risk of a blood cancer, lymphoma. And for that reason, it's nearly always confined to people who are having a kidney because they've got kidney damage and need a kidney transplant. It is life-changing. I had a lady who so struggled to manage her diabetes, in the end ended up with a renal, on dialysis. She had a renal transplant. They put in a pancreas, and she's a new woman. Fantastic. But it's very rarely done. Islet cell transplantation is also life-changing for the very few people who have it. But again, you have to be on immunosuppressives. That does increase your risk of cancer. But again, when it works, it's fantastic. The problem is you need 2 or 3 transplants of people who died to have one. And so numbers are very low. Finally, new forms of glucagon are there as an emergency therapy. Nasal glucagon is available in the States. You just have to puff it into somebody's nose. It's really quick, no skills needed. And refill glucagon, which can last forever and ever. You just have to stick the needle in somebody's leg and press the plunger and it'll work. Those will be available very soon in the UK, and again, need to be available to everybody in my view. So, hypoglycemia is important for different ways. Repeated episodes, tight control, long duration, I've explained, impairs protection, increases vulnerability and severe episodes. Occasional episodes in people with high glucoses can be dangerous. I think it can trigger cardiovascular events. And prolonged asymptomatic episodes overnight, pretty rare, but there is a very rare condition called dead in bed syndrome, which I think is probably related to hypoglycemia at night, but almost certainly in a very few individuals, and we still don't know who they are. So I have been reflecting that we have have been saving lives with insulin for 100 years. We've put men on the moon. We have changed computing from a slide rule to a computer. We have changed flying in this way, and yet we have not cured type 1 diabetes. That is extraordinary. And I think actually insulin discovery stopped people curing type 1 diabetes because everybody thought, oh, well, that's it, solved now. And I think only the people who know that that's not the case are the population of the world with type 1. And here they are. And I just think that people who manage type 1 diabetes and actually type 2 diabetes on insulin are incredible. They do things that most doctors and nurses wouldn't have a clue of. They put up with it and the downsides. And, you know, this is what insulin looked like 100 years ago on the left. And we now have great technology, but basically you're still having to do the same thing that we asked people to do 100 years ago. I mean, I'm sure that diabetes will be cured in the next 100 years. I won't be there to see it. But in the meantime, I'm afraid we have to do better in preventing such an important side effect, which can make life a misery for so many. And with that, I'm going to stop sharing and answer any questions. And thank you very much for listening, for those who've survived the last hour.
Yeah, thank you.
So I'm happy to answer questions. I've had a list of questions. I can see there's quite a few in the chat as well. So I'm going to start them, and then I've got some more, and I'll keep on going till you tell me to shut up, actually. Oh, thank you for the nice things. I don't think I deserve them, but that's very good of you. The first one, isn't it funny how the symptoms you didn't feel before you check? Cameron, yeah, I think that's really interesting. So, you know, hypoglycemia is incredibly subjective. And we're doing studies at the moment with a huge amount of European money, 25 million euros to be precise, which I and other of my colleagues working with drug companies, Novo Nordisk, Eli Lilly, and Medtronic and Abbott, all those companies you'll have heard of, have put their money into us trying to improve treatment for hypoglycemia. And we're trying to see, if you don't know you're low, do you have bad effects on your brain and quality of life, you know, such as not working well the next day, compared to when you've looked at, scanned and said, oh, I have been low. I think this is really having a bad effect on me. Just to see what is due to the glucose itself and what's due to the psychological overlay. Now, you might say it doesn't matter. And I think I probably agree with you, but we'd like to know that. So we don't know the answer to that question. It may be purely that the adrenaline's gradually kicking in, which is why you feel so lousy. So another question. I'm recently diagnosed, been given an A1C target 42, which is hard work to achieve. Maybe I need to challenge this. Well, if you're on insulin, in my view, absolutely. There's very little evidence, frankly. I'm probably going to get lots of bad Twitter comments to say I'm being dangerous, but there's very little evidence that, you know, running at 55 instead of 45 makes any difference to you. Indeed, there's recently been some studies which I think are a bit of a concern. You'll all have heard of the DCCT, which proved that tight glucose control, or some of you will have heard, a trial in the 90s, and it proved that tight glucose control prevented eye disease, foot disease, and nephropathy, kidney disease. But it was a crappy way of keeping people tightly controlled, loads of severe hypoglycemia, which they put up with. And what we now know after, 30, 40 years, those people have been followed and they have a degree of cognitive impairment, those who had repeated severe hypoglycemia. It's taken years and years to show up, and it's persuaded me, well, I didn't need any persuasion, that we've got to be realistic with the treatments that we have. I do think that the new closed loop pumps and all those things are going to make it safer and easier. But, you know, for me, if you keep your glucose at 55, a time in range at 60, 70%, that's fine. I mean, you're doing absolutely fine. And there's no reason that you should do that. Next question, screenshot to the slides. Yes, I've got the PDFs. I've sent them to Lindsay and Shirley. I'm very happy for everybody to have those. Some of my friends don't like their slides to be revealed because they've spent so long preparing them. Well, I've had lots of help preparing my slides over the years, And if I ever see them, which I do, in somebody else's talk, I'm really flattered that they've stolen them. So thank you very much. So you can steal the slides and use them for anything you want. That's no worries at all. Yes. So there's a question about the pancreas contributing a bit. That's really interesting. There is some evidence that if your pancreas continues to work a bit, in other words, you make a bit of insulin, which can happen in type 1 diabetes, then you probably still make a bit of glucagon. And we tried to test that theory, about 15, 20 years ago. And I think we probably did. So if you still make a bit of insulin, the right messages get to the glucagon producing cells next door and they release a bit. And we think that reduces the risk of severe hypoglycemia. Now, lots of people have said, well, if you're really super tight on your glucose levels for your first year or two, you're going to keep your insulin going longer. Do you know, I'd like to say that works, but I'm not convinced. But what's a bit more exciting, that some of the immune therapy drugs, which have been tested out, begin to look as if you can keep the pancreas glowing at least a little bit longer. And that's just about to be released in America. I hope it will happen here. So people who've just got diabetes may be using these drugs. They're not without a bit of side effect, but if they could keep your insulin going for 10, 15 years, then you probably would have less hypoglycemia. So that's one. So is blood glucose awareness training different to Daphne? Yes, it is. Daphne reduces the risk of severe hypoglycemia by 50%. That is fantastic. It's cheap as chips, and yet mad doctors and nurses in this country still don't realize how important it is and don't offer it. But even those who offer it, only 10% take it up. Why is that? Because they should sell it like they should, probably like being a second-hand car salesman. It's so important. What's the best way to stop a hypo at night when you're asleep? Use continuous glucose monitoring and make sure your background insulin is right, is what you should do. And either be on a pump or use one of these really new, I think the really new long-acting insulins are probably the best background insulins because they truly can keep your glucose level if you don't eat. Now, what I don't mean that you shouldn't eat. What I mean is that you can separate your meal-related insulin from your background. And if you keep it stable at night, then you're going to be fine. Yes, Lindsay says time in range of 70% is a game changer. I agree 100%, but it comes with another really important warning. I was involved in coming up with those recommendations. Less than 4% below 4, please, and less than 1% below 3. That's just as important. In other words, you don't have, you should not sacrifice not going high before. Something about dementia. Yeah, there is research about it. It is a bit of a concern, but my view is you need a lot of recurrent severe hypoglycemia to do that. Oh yes, somebody asked about rebound. Rebound does not exist. Right, you've heard it here, and you won't believe me. Most doctors and nurses don't believe it. It's a myth. It absolutely doesn't exist. It's a great idea. So for those of you who don't know what rebound is, or have been told about it, even Daphne trained nurses on Daphne courses talk about rebound. It doesn't exist. I'll say it again. It does not exist. Almost all the rebound hypoglycemia, in other words, a high glucose after you've been low in the night, is because you've overtreated a low. Or your insulin has run out and your glucose will go up. And you might say, well, how can you be so sure? And the answer is we've done studies on using continuous glucose monitoring to show it. And I told you right at the start, if you haven't forgotten, because it's long ago, that at sleep, your adrenaline goes to sleep itself. So you don't have a way of automatically pushing your glucose up if you have a really low hypo. And that is why hypos are more common at night. So if you're high in the morning, it's because you've got something called a dawn effect, because your hormones are being produced to wake you up, which some people have, or your insulin has run out. You need to have a better background insulin, or you treated a hypo and it's gone through the roof, which I'm sure you all know. How do we get on blood glucose awareness training? Well, if you've done a Daphne course and you're having loads of bad hypos, we probably will introduce it in Sheffield, even though we haven't seen the results of the trial. And Stephanie and I and a few others have been discussing it, that we will make it available. It's, I think, a really good course. There's something called blood glucose BGAT, which is blood glucose awareness training, but I think it will become available. And I can't see any hands telling me to shut up yet, but I could do, but maybe I'll just stop and I'll see if Shirley or anybody else want me to answer any other questions. So I'm going to stop and wait for somebody to say something to me. But I can't hear anything.
I'm just posting some of those earlier questions.
Okay. I've got them here. I can go down my list if you want me to. It's whatever you prefer, you know.
I think you've answered some of them, but maybe not all.
Okay, so if people have still got an appetite, I mean, we've still got a few people on the thing. When I'm down to myself, I'll know to stop, actually. Let's see. So I talked about rebound. If I haven't explained it, Lindsay, have I explained rebound doesn't exist, or do you want me to go over it again?
I think you have, sorry.
Yes, I do, yes. I think you've explained that one.
Good. Can hypos make you depressed? Absolutely. We're doing loads of research on quality of life. There's a thing called diabetes distress. It's not depression, and it's specific to diabetes. The trouble is, it's a sort of mishmash of everything that is going to screw you up psychologically about diabetes. I mean, I can't imagine what it is like every meal of every day not to take it for granted, or to have a drink, which I'm going to do tonight, and think, oh, I've got to keep high, or I'm going out for a meal. How much can I eat? When should I take my insulin? And for the last year, 18 months, particularly since the pandemic, and I've been looking at people's Libra views with them, I'm saying, how long do you leave between injecting and eating? And they say, oh, well, sometimes even after, but just before. And I say, how long do you think it takes for quick-acting insulin to last? And they say, oh, 20 minutes, some say 10. Some people who know say 30. It's 40 minutes. Even if you inject insulin into a vein, which I've done during studies, your glucose will not fall for 20 minutes. So if you think under the skin, it's got to get into your bloodstream and get around to the liver and get going. And in pregnancy, where we're completely fanatical about keeping glucoses from rising, we say 30 to 45 minutes. Now, do I think that's practical? Absolutely not. It's a completely doctor thing to say, hopeless. But it's the only way you can match food to insulin. And all of you who've got Libra and can see your you know, what I call alpine peaks as the glucose goes shooting up. There's only one reason that that's happening, is you haven't matched your quick acting to it. Not because you're bad or you're not doing it. It's because probably you haven't been told enough times. And then see if it makes a difference. See if I'm right. Wait 30 and 45 minutes and wait. And instead of your glucose going like that, it'll go like that. And the other thing is it'll help you reduce late hypos, because what happens, your glucose goes up high. You think, oh, I better take a bit of extra insulin. And if you then take a corrective insulin, the other insulin will get going and you'll have a low. It's really dangerous actually on pumps where we talk about stacking, because it's so easy to give yourself an extra shot of insulin. Don't do it. Just leave a gap. I mean, but coming back to the question, of course, if you've got to do all that day after day, no holidays, it's going to get you down, particularly when you do everything perfectly and your blooming glucose goes high again. What the hell did you do wrong? And people beat themselves up about it. Don't beat yourself up. Just say you've got useless treatment. These tools are not very good. With due respect to Frederick Banting, this is a great way of giving treatment. You know, think about thyroid doctors who have it easy. They're endocrinologists like me. Thyroid disease, underactive. What do? You take a tablet in the morning, you forget it. I don't think diabetes is like that. And it's not going to be. So it's going to stress you out. In fact, I'm surprised everybody isn't walking around in a loony bin if they've got type 1 diabetes. So I just admire all of you for just doing this, because you're better than me. I couldn't do it, I tell you. So that's depression in a nutshell. I've done unawareness. Symptoms change. I hope I've explained why. Lindsay, your question was the most difficult. I don't know how to answer that question.
What was the question?
Slimming diet. The question is, whenever I've gone on a slimming diet, I have loads of hypos and had to eat things not in the diet. Well, you're eating the wrong things, mate. That's what I think. And you say it's the basal that's problematic. I guess there's just a possibility that if you lose loads of weight, or you begin to, your insulin sensitivity may change. And then if it does and you become thinner, then yeah, you've got to reduce your background. But somebody should have told you that. Or you should be able to work that out for yourself. I think the one thing which is amazing after Daphne is that nobody ever changes their background, or very rarely. And if you're on a pump, people hardly ever do basal testing. And I'm thinking, why? I mean, it's boring because you can't, eat carbs for a day and then have a look. But surely you could miss a couple of meals and just see what's happening to your glucose. Is it so difficult? I don't know. But because all of you using Libra, and for type 2s, you will in the next 5 years, I don't know when, look what happens to your glucose when you go to bed and when you wake up, and see if it's a flat line. If it's straight, you're on the right now about a background. I mean, that's surely, is it more difficult than that? Maybe, I don't know.
I think it is.
Yeah.
Why? Tell me why.
I think I eat quite a lot in normal life, but it's all like Daphne worked out insulin wise. But then on a diet, it seems like there's a lot less food. So even if I do like, 1 unit to 10 grams of carbohydrate, I'll still go hypo.
So why can't you, it's like, always think it's a bit like exercise. I think the way we teach exercise is a joke, actually. And I say that because some of my best friends are people who spend their lives doing studies on exercise and what they should advise. And there's all these websites, and they tell you what to do. But you know what? Everybody is different, and you have to work it out for yourself. And I'm sorry, because what works for one person in exercise will not work for another. And you now have the ability to do that with continuous glucose monitoring. You definitely do. But it takes a hell of a lot of work, and I'm sure dieting is the same. I think if people lose weight rapidly, even over a week or two, then that probably changes their sensitivity. It probably changes their meal-related requirements. They're eating different foods. So we know that the amount of fat and protein is going to affect how well you match your insulin and your dose. And it just makes it even more difficult. And my view is that most people don't vary their diet hugely. We probably have about 20 stock meals that we eat regularly because we like them. Then we would get, that's what I would try and do, and get used to those. If I'm going out, I don't know what I'd do. I'd probably take half my insulin before and then readjust when I got home, because I know it'll go up the creek. But, you know, again, is it fair to take 2 shots of insulin when you go out? No, it's not fair. But it's not fair having diabetes, you know, so tough. And of course, I'd say that tongue in cheek. It's hell. But, you know, we can't cure that.
I think I did, like, Daphne just utterly changed my life. And I can remember, like, on day 3 of Daphne, going to what was, I think it was Safeways, and I got the giggles in the biscuit section because I'd never been allowed to have biscuits. And then when I got to the breakfast cereal, I just collapsed. It was so exciting. But that was in 2000. And I think things have changed in the last 21 years. And I actually would quite like not just a Daphne refresher, but to do like a lot of Daphne again, not just...
you are allowed to. We do have people doing it. They're usually, and so I want to emphasize, there's no... People are, I mean, it's terrible when people come and say, I've been bad or I've been good. No,
Yeah.
You've had to live with diabetes, and sometimes it's just harder. And I wish, you know, it's interesting. Healthcare professionals are told off for using language which is completely wrong. And we talk about bad and good control, but I hope we now talk about time in range or being close to target. But people with diabetes are beating themselves up. I've been good, I've been bad. And I think people struggle. I personally think people who are running high are not bad people. Engaging with self-management is so hard, and to do it day after day is impossible, in my view. At least it would be for me. And somebody said you need the George Cross. Well, yeah, I don't know what you need, but you certainly need healthcare professionals who aren't specialists not to beat you up, that's for sure, because I think that's probably one of the worst things that I come across all the time. And they haven't got a clue. So I haven't got any easy answers for that, I'm afraid. That's one I can't do. And Liz has said, yeah, I think, Liz, you're absolutely right. And you have to work it out for yourself. And if you can't, and I think you need a healthcare professional who understands you and will work with you, will not tell you off or be exasperated, because sometimes you just say, you know what, I just don't know what happened there, you know, and try again and see if you get a better result. Because on the whole, everybody can do pretty well. I think we're probably just about out of time. Actually, I love the chat. There's some fantastic stuff there, which I should send to everybody. Bertie Online, yep, useful. Of course, I'm a bit biased. There's conflict of interest. I think Daphne is the best. And I think Daphne Online is pretty good, but I think we need face-to-face. We need to look people in the eye. It's kind of ironic that I'm back to doing face-to-face, but I can't see people's faces. And although I am totally against everything changing on Monday, I really look forward to seeing people's expressions and body language, because that tells me such a lot about how they're feeling about their diabetes, actually. Okay, any final burning question? If not, Kat.
I ask something, Simon? As a GP, it is quite sad to hear that some people don't have faith in their GP or their practice nurse. And I just wondered, it doesn't go for everybody, that comment, but from your comment and from the feeling that I get sometimes, it's been quite an issue, and particularly from the psychological and the understanding of the emotional side and the emotional burden of living with diabetes. So I get that very much so.
Jenny,
I would love to know what the training needs might be, because now the pandemic, we're trying to bring people up to speed again of getting back to regular input for helping people to deliver better diabetes care. So I just wondered if there are a few take-home messages from everybody that I could take and be enlightened as to what sort of things that GPs ought to be learning better.
Okay, Jenny, I'm going to give you my prejudicial view. And of course, for those who don't know Jenny Stevens, she is 1 in a million. Well, she is virtually 1 in a million, because she's a GP who is really interested in diabetes. We have 4 or 5 spread across Sheffield, and they are such a breath of fresh air, and they're the people I really love talking with. But of course, the ones who I think really need to have a discussion don't ever join our meetings, Jenny. That's one of the problems. And people do get told off. They get told off all the time. And I think it's, you know, people, whether they're type 2 on insulin or type 1, are getting such a lot of experience and have, you know, lived experience with diabetes is a precious thing, which we now grab when we're designing any of our research, because unless you have those people, you're not going to get good research. And the sad thing is, the people I really want, the people who hate diabetes, can't engage, and we want to do better by them. So what are the training needs? If it was me, I would bring people to training with lived experience, and they could tell you some anecdotes which would make you shudder. The worst one I can tell you about is a housekeeper at Sheffield Teaching Hospitals in urology was looking after one of my patients who was overweight and on insulin. So she came round to see him last thing at night, and she said, I know you got a diabetes sticker. You're not allowed to have an evening snack. And he said, no, I've got to have insulin, because a snack, because I'm on insulin and I'll go low in the night. No, I know, you're not going to pull the wool over my eyes, she said. And she went on her way. And guess what? He had a really bad hypo in the night and complained. And I got to hear about it. And I wrote to the manager, senior manager of urology. And I said, this is absolutely appalling. We've got to do something about this. And she wrote a really stinking email back saying, it didn't happen, doesn't happen in urology. I'm not going to do anything about it. And he was very rude the next morning, she said.
It would be.
Yeah, too right, mate. It was.
Hypo would be.
So that's the worst. But I think it's an example. And of course, she's not a trained healthcare professional, but this attitude that diabetes, you just stick to your doses and eat what you should, no cheating, and you'll have a perfect glucose. It's truly believed by general nurses, not just practice nurses, throughout the world, I think. And they are a menace to society, at least type 1 society. And I don't know what you do. We've tried link workers. We've got a fantastic inpatient team who now do all the work, but they just, and insulin is scary. I mean, I became a registrar before I did diabetes. I was terrified. And in fact, I remember Pat Clark, who's one of my best friends now. I was a registrar in gastroenterology, and we had somebody come in with undiagnosed diabetes who became my patient. I don't know why, because she must have thought I was crazy. We kept her in for 3 weeks trying to stabilize her diabetes, which we couldn't do in hospital. Oh, I'm not surprised. And she was desperate to see her kids. And this nurse, Pat Clark, came in and wrote in the medical notes. You're not allowed to write in the medical notes. At least you weren't in the 80s. She said, why don't you send this patient home? You know nothing about diabetes. And I thought, a nurse can't write that in the notes. That's not allowed. And then I thought, she's right. We know nothing about diabetes. Sent her home. I mean, that's the standard in the 1980s. Do you think it's much better now? I'm sure all these people on the line with type 1 diabetes, and some probably type 2, because that patient I told you about was type 2, could tell a horror story or two. And then they, and you know, Jenny, they play games. I asked them, they sit in there with a practice nurse who's giving them advice about diabetes, and they're thinking, this is rubbish. I'm going to get out of here. I'm not going to say anything. I don't want to hurt her feelings, but this is a waste of my time. And they often get told to come in for a review because they, you know, because of QOF, and it's shameful. Somebody nod or wait, say I'm right, because I'm right. I know I'm right. Anyway.
Yes, you are.
Yes.
And
Yes.
This came in the corporate activity we did, Lindsay, wasn't it? It was collecting people's comments. So I won't hold up the meeting up any further, but thank you. And I will think of some imaginative, creative ways, and I'll run them past everybody and say, do you think this would work?
Good. No, I look forward to our next meeting. Actually, the only good thing I can think, well, there's two good things about the COVID pandemic. One, it got rid of Donald Trump, and and the second, we're now having really good virtual meetings across Sheffield, because we still do have one or two at practices, and about 6 people turn up.
Yes.
But when you can get 30 nurses, then you can really get to people. I think that's really useful, and we should probably continue that because it means that people can join from their own practices, and it works really well. I just wish they'd ask more questions, really. That'd be, I think.
Right, okay, well, I shall remember that, and those meetings have continued through the pandemic, and I've done a bulletin every week to get people's interest, so that's continued, but it's the soft stuff that's so important, so I shall bear that in mind. Thank you.
Lindsay and Shirley, I probably should go. I'm about to get roasted by my wife.
Right.
My grandson is definitely asleep. We've been babysitting him for 2 days while my daughter, who's a nurse at the Children's, goes off on a holiday. Sadly, not in Las Vegas, but where she wanted to go, but in Lincolnshire, I think.
That will come.
But I hope that was okay. It was lovely to talk to you all. Happy for everybody to have the slides, and happy for you to pass any other questions or disagreements. That would be great.
Well, yes, thank you once again.
Right.
It's been a wonderful presentation, and it's opened my eyes. I'm type 2. I might have had hypos, but not realised. So thank you very much. Okay. So yes, enjoy your grandchildren. Is it grandson?
It's a grandson, and actually my granddaughter, who's been in Brighton, lucky thing, this week. She lives in Scotland, but she's coming to stay with us this weekend. So that'll be
great. Well, there you go. All under one roof.
Okay, yeah. Okay, bye.
Bye.
Thank you, Simon.
Thank you. Bye now.
Thank you very much.